He asked me to stick to the time 15 minutes, but my lecture is more than 15 minutes, so you can find all of this detail on my scientific page on the Facebook and this one. And I will address 4 points. Number 1, how to counsel and to give information to the patient before IVF. Number 2, the evaluation. And the evaluation of the patient before IVF constitutes of 6 steps. And if there is any associated surgical or medical condition, you should treat it before referral her to the center. And lastly, what is called the preventive treatment. So we will address one by one. First, the counseling and the information to the patient should tell her how pregnancy occurs and what is the indication of her procedure. Why you referred her to do exit. And then, in simple ways, what is the steps of the procedure. You should tell her what is the pregnancy rate in general and what is the pregnancy rate in her particular condition. What is the special problems you will face? The patient is obese, the patient is suffering from polycystic syndrome. So you should tell her in a sensitive, non-threatening way what is the condition. After that, financial is very important. And at the end, you can give her a handbook of information. Just we want to review what are the indications of ICSI. Male factor infertility constitutes now about 40% of the indications of ICSI. And in severe semen analysis, you don't waste the time of the patient. Don't waste her money. And in this condition, you should refer her directly to ICSI. And by severe male factor infertility, we mean, according to the WHO cutoff level for the normal semen, if the normal forms by the strict criteria is less than 2.5%, the count is less than 5 million, or the total mortality is less than 10%. Any one of this condition, please refer the patient directly to ICSI and don't waste time in giving her any treatment. The presence of azoospermia, either it is obstructive or non-obstructive, is an indication of ICSI. Tubal factor infertility, the moderate and the severe tubal disease, and the presence of hydrocephalus is an, and according to the NICE, don't depend on the volume of the ovary, don't depend on the ATP, and don't depend on the estradiol. But you should depend on the total antral follicle, the antimullerian hormone, and the FSH. And we have a lot of cutoff level for the lower response and the high response. But this is what is mentioned by the NICE. For the antral follicle, 4 or less, this low response, more than 16 high response. For the antimullerian hormone, 0.8, and high response, 3.5 for the FSH, 9, and for the high response, 4 or less. The least sensitive one is the basal FSH. The fourth point in evaluation of the patient is endocrine evaluation. It is not a matter of investigation to be requested, but you should know what is your objective of asking or requesting this test. For day, FSH only if you have a regular prolonged cycle. For prolactin, only if you have ovulatory disorder. And by ovulatory disorder, we mean anovulation or luteal phase defect. Or you have galactorrhea. This is an indication to request for prolactin. If the patient is clinically suggestive of hypothyroidism, you should ask for TSH. The fifth point is to do basal vaginal ultrasound. And the best recommended timing for this is between day 8 and day 12. And by this basal vaginal ultrasound, we will assess the uterus and to see if there is an abnormalities like any anomalies or tumors. We will assess the ovaries and to count the antral follicle count and to see if there is any polycystic ovary syndrome or tumors And if it's diseased, it will be visualized, the hydrocephalus will be diagnosed. The 6 points is evaluation to do hysteroscopy or not to do. And in this condition, we should address this in 2 conditions. If it is the first trial of IVF, and there is there is 1 randomized controlled trials and 5 non-randomized controlled trials, and they found that there is a significant higher clinical pregnancy rate. But this trial was criticized, and now we are waiting for what is called the site study, multicentric randomized controlled study, to see if the prior hysteroscopy before IVF is beneficial or not. The second condition, if I am faced with a patient with a repeated implantation failure, it was found that in this condition, about 9 to 13% there is increase in the pregnancy rate. This was till the last issue in 2014, but there is a meta-analysis done by Tariq Touhi, and he found the hysteroscopy before repeated implantation failure doesn't improve IVF outcome. Now, the fourth point of my preparation is to manage the associated condition. And we have a medical condition and a surgical condition. And there is no time to go for all of these conditions, but we will select some condition. How, if there is endometrioma, if there is hydrocephalus, if there is fibroid, this is the surgical condition. What is about if the patient is obese or suffering from polycystic ovary syndrome, if she is diabetic, if she is thyroid disease, and so on. Let us start if you are confronted with a patient which is obese. In this condition, it is unethical to refuse to treat her. So, what you will do? Number 1, to ask her what is your age. If her age is more than 35, go straight forward and treat her. Because the detrimental effect of age is more than the detrimental effect of the body mass index. Number 2, the patient is below 35 years. In this condition, I will do a counseling. But this counseling should be in unbiased manner, avoiding blaming her and maintaining her dignity. I will inform her the effect of raised body mass index on IVF outcome and how it will decrease the outcome of the IVF. I will tell her about the effect of the weight loss on the IVF treatment outcome and the effect of raised body mass index on pregnancy, and I will encourage her to wait for weight loss. After all of this, an informed consent, I wish to proceed under these circumstances. And preconceptionally, we will screen for diabetes and optimize the glucose control, will screen for thyroid disease because obese are high risk for thyroid dysfunction, and ask her to have a healthy diet and lifestyle and give her prenatal vitamins. Weight loss, hypocaloric diet, lifestyle changes, to give her drugs to, but there is no drug in the market which will cause losing of weight. If you go for this, the early step, after use for 1 year, only 4 to 7 kilogram the loss of weight. The bariatric surgery in morbid obese is very effective, and there is a very nice paper about the treatment of obese polycystic ovary syndrome with bariatric surgery. For selecting the gonadotrophin dose, the gonadotrophin dose should be increased after exclusion of the polycystic ovary syndrome. As regards the patient is diabetic, and in this condition, preconception counseling, weight loss, and to get the optimal body mass index, diet glycemic control, and to optimize the hemoglobin A1C before the start of the treatment. If the patient is taking statin because her levels is high, it is better to stop statin before starting the IVF. During controlled ovarian stimulation, we should closely monitor the glucose status because there is changes during the controlled ovarian stimulation, and during oocyte retrieval, the patient may be high risk of infection, of course, and also of deep vein thrombosis, and in this condition, thromboprophylaxis and prophylactic antibiotic. For men, you should know if there is erectile dysfunction or not, because in the day of oocyte retrieval, it will be a drama. The patient cannot give the sample to you. So you should be treated and know if he is able or not. As regards thyroid disease, we have two types of thyroid disease, the hypothyroidism and the hyperthyroidism, and we should manage both before starting IVF. And if the patient is hyperthyroidism and taking carbimazole, we should shift to propylthyracine, because the congenital fetal malformation with propylthyracine is less than carbimazole. There is no need at all to send the patient to a medical doctor, but just to keep the free T4 at the upper third of the normal range. There is an indication to give eltroxin in euthyroid patient. The TSH is normal. As we know, the normal range of the TSH is wide, from 0.6 to 4.6. And my objective is to keep the patient TSH 2.5. During the ART, please, if the patient is hyperthyroid and taking propylthyracine, there is a need to reduce it. But if the patient is hypothyroidism, there is a need to increase the eltroxin. Especially when you are confronted with ovarian hyperstimulation syndrome, there is a marked elevation of E2, and in this condition, you should increase the eltroxin. I will pass all of this, the endometrioma, but just we should avoid surgery if there is a history of previous surgery or the ovarian reserve tests are reduced. And if you have an endometrioma which is 4 centimeter and surgical treatment is not recommended or not planned, to give the extended long agonist protocol for 3 months. During oocyte retrieval, please avoid puncturing or drainage of the endometrioma and give intravenous antibiotics in all cases of endometriosis. Hydrosalpinx, it can be diagnosed before starting IVF, and in this condition, salpingotomy or tubal occlusion. But if diagnosed during the ovarian stimulation, we can aspirate it, or we can freeze all the embryos and to transfer in the next one. If there is a fibroid, myomectomy is indicated before IVF. If any submucous fibroid, it should be we should do myomectomy. If we have intramural fibroid distorting the endometrial cavity, or its size is more than 5 centimeter, it is an indication for myomectomy. What's about cervical stenosis? We should do trial transfer to discover this cervical stenosis. But if we are confronted with cervical stenosis, we should do mechanical cervical dilatation, and it is recommended to be done at the start of the IVF cycle, not at the time of the oocyte retrieval. Or if I have this cannula, the Tuaco method, which is transmyometrial embryo transfer, we will bypass the cervix and we will go through the myometrium and inject or transfer the embryo through the transmyometrial embryo transfer. Or the last resort is to do hysteroscopic canalization of the cervix. The last slide is the preventive treatment. So again, we have counseling and information. Number 2, evaluation. Number 3, treatment of associated condition. And lastly, preventive treatment. In many centers, they are giving for both the parents doxycycline, fluorocorral, flagellin. This is for both. And for the wife, they are giving folic acid and aspirin. And if the patient is suffering from ovarian hyperstimulation syndrome, they are giving metformin to decrease the incidence of ovarian hyperstimulation syndrome. شكرا لحضراتكم.